Hi students, this little presentation will be for chapter 26 and it is about disorders of blood flow and blood pressure regulation. There's a few kind of initial slides that I may go over somewhat quickly because there are activities embedded into the modules in Canvas that I think will better kind of cover these pieces. So I will mention those when I get to them. Otherwise, we'll kind of go through the material a little bit more step by step. Okay. So we're going to start out just kind of looking at the typical structure of an artery because it's important to understand that structure when we start talking about some of the disorders or things that can go wrong, like atherosclerosis or aneurysms or dissections. So a typical artery has this what we call tunica externa. It's this thick kind of collagen and elastic fiber coating. It's important to have something that's elastic in nature, but always also kind of strong in an artery because it helps it to stretch. It needs to have that stretch and compliance, but it also needs to be able to withstand relatively high levels of pressure. So that's the tunica externa, that's the outer coat. And then there's the tunica media, which is kind of the middle coating of the artery itself, and that's really composed of smooth muscle cells. And then the tunica intima, or the inner coat, is a thin internal elastic membrane covering some connective tissue, and then covering a very thin layer of endothelial cells that line the inner lumen of the artery itself. And we're going to talk a bit about those endothelial cells in general because one of the things that often leads to atherosclerotic plaques is damage to the endothelial tissues, or those endothelial cells right inside of those lumens themselves. So the endothelial cells have a lot of different functions, and we've talked about many of these already. So they control the transfer of molecules across the vascular wall. They control things like platelet adhesion and blood clotting. We talked about kind of that platelet adhesion and aggregation kind of piece when we talked about hemostasis. They modulate blood flow and vascular resistance. They metabolize hormones, regulate immune and inflammatory reactions, and influence the growth of other types of cells. So lots of functions in those endothelial cells within the arteries. So endothelial dysfunction describes potentially reversible changes if we take away what's causing it in the endothelial function in response to some kind of environmental stimuli. So some common things that fall into that environmental stimuli bucket that can cause endothelial damage. So products of inflammation, so things like cytokines, bacteria and viruses, hemodynamic stress. So long-term hypertension is a big cause of endothelial dysfunction. Lipid products can damage the endothelial lining. So patients with elevated levels of cholesterol, specifically LDL cholesterol elevation, get endothelial dysfunction. And then hypoxia is another cause. So we might see this. This is part of the mechanism of increased incidence of things like atherosclerosis and cardiovascular disease in patients with things like sleep apnea, right? Where they're having these episodes at night where they're not breathing, they get hypoxia, and that over time can start to lead to endothelial damage and dysfunction. So let's talk a little bit about those vascular smooth muscle cells that make up that tunica media, or that kind of middle lining of the artery wall itself. So they are responsible, that vascular smooth muscle is responsible for both vasoconstriction, or narrowing of the arteries, and also dilation of those blood vessels. And this is largely controlled by ANS, or autonomic nervous system regulation. You'll see some of that in one of the video exercises that you're going to do. And then there's also some local regulation, specifically the actions of nitric oxide. Let's see, let's move this over. The ECM, or the extracellular matrix, and growth factor elaboration. So the vascular SMCs, or smooth muscle cells, synthesize different biological molecules like collagen, elastin, other growth factors. They synthesize cytokines. And those molecules can infiltrate into the tunica intima into those inner layers of the vasculature in response to things like injury. And that infiltration is essential for healing. So if there's damage, to those intima linings, we need that ECM, infiltration to heal that damage. But that's also an extensive contributor to these pathological processes. So again, if we get, going back to that endothelial dysfunction or damage over time, that stuff leads to this infiltration by all of those biological molecules synthesized by smooth muscle cells that go in to try to heal that damage. And that's the contributor to atherosclerotic plaque formation, which we'll talk about. Okay. Okay, so let's talk a little bit about the regulation of systemic arterial blood pressure. So we need an extensive, amount of regulation to keep our blood pressure in this kind of hemostasis or this homeostatic set point, right? So there's a lot of different mechanisms that control this. There's some acute regulation pieces that are neural and hormonal, and then there's some more long-term regulation that's really driven by the kidneys and their regulation of fluid volume. There's also some regulation that happens with our circadian rhythms or some circadian variations where we see these drops in blood pressure at about 10 to 20% at night. In some patients who start to kind of develop hypertension, one thing that we notice is that their circadian drops in blood pressure start to reduce. So we don't see that kind of good drop in blood pressure at night, which is probably cardiovascularly protective to have that happen. So it's not a good sign when we start to lose that circadian drop. For you guys to do a little bit more deep dive into some of these mechanisms, both neural and hormonal regulation in that acute phase. Again, there are activities that you should have done already on Canvas to kind of answer those questions. Okay. Okay. So let's talk a little bit more about diseases of the arterial system, and specifically we're going to talk about things like dyslipidemia or hypercholesterolemia and atherosclerosis. And we'll also talk about disorders of systemic arterial blood flow. We're not going to talk really anything about vasculitis. I'm going to kind of skip that piece, but we are going to focus on arterial diseases of the extremities and also arterial aneurysms. So let's start with dyslipidemia. So just a little bit about the different lipids that are found in the body. So one is triglycerides. Triglycerides are the primary fatty acid used in energy metabolism. We've talked about the presence of many different phospholipids in the body too, and they are very important for a lot of the structures within the body, specifically things like constructural constituents of lipoproteins. They make up different blood clotting components. They make up the myelin sheath that covers our nervous tissue, and they make up the cell membrane, so semi-permeable membranes. So lots of uses and lots of applications for phospholipids in the body. Cholesterol, which we're going to talk about, has a very similar chemical activity to other lipid substances. And hyperlipidemia, that is an elevated level of one or all of the above components. So there are several different classifications of lipoproteins from high density to low density. Chylomicrons are our lowest density lipoprotein. They contain 80 to 90% triglycerides and very low levels of protein. So these are responsible for carrying much of the triglycerides in the circulation. VLDLs, very low density lipoproteins, also carry large amounts of triglycerides. They are 55 to 65% triglyceride. We also have some intermediate density lipoproteins, and then the ones that you're probably even more familiar with, which are LDLs and HDLs. So LDLs are low density lipoproteins. These are the main carrier of cholesterol within the body. They're made up of 10% triglycerides, 50% cholesterol, and 25% protein. And finally, our HDLs. HDLs are important because they help to facilitate what we call reverse transport of cholesterol. So they'll actually go out and grab cholesterol from peripheral tissues and carry it back to the liver so that it can be secreted into the bile. So those are actually our protective lipoproteins, again, because they'll help to kind of clear excess cholesterol from peripheral tissues and excrete it out of the body. So when we talk about patients with elevated cholesterol, the cholesterol that we're most concerned about is LDL cholesterol. And what we want with HDL cholesterol is to push those numbers up higher. So things like exercise and stress reduction and good dietary practices are things that will increase a patient's HDLs. And again, those are protective to the cardiovascular system in general because of that cholesterol removal. So some patients have what we term primary dyslipidemia. This most likely has a genetic basis, runs in families. And what we see in these patients is they develop high or elevated levels of cholesterol that is independent of any other health problems or any other individual behaviors. It just seems to develop regardless of what the patient does or any, concomitant health problems. There's also something called familial hypercholesterolemia, and this also has a genetic component, but the difference here is this is a genetically driven cholesterol level that causes HDL levels, high LDL levels to start from birth. And it's not just the, kind of slightly elevated cholesterol levels like above 100 or above 240 that we see in primary dyslipidemia. These are patients who on average would have LDL levels of like 350 or greater, and sometimes up to all the way to like 1,000. And it starts again really early on. We'll see these elevated levels of cholesterol from birth. It usually takes time for them, of course, to develop the cardiovascular side effects, but they will develop those earlier than most. So again, another genetic component, but different than that primary dyslipidemia piece in both onset, timing, and severity. And the final piece is secondary dyslipidemia, and this is elevated cholesterol that's associated with some health problem or some behavior. So some of the causes of secondary dyslipidemia are things like dietary factors. So, elevated increased intake of things like trans or saturated fats would be one example here. Patients who are obese, and any of the metabolic changes that are associated with type 2 diabetes. Those are heavily implicated in secondary dyslipidemia. Other systemic disorders that can interfere with lipid levels and lead to secondary dyslipidemia are things like hypothyroidism, nephrotic syndromes, obstructive liver diseases, medications like beta blockers or estrogens or protease inhibitors that we use to treat HIV infection can also increase lipid levels. So those are, again, some secondary causes. So some definitions of hypercholesterolemia. So serum cholesterol levels greater than 240 milligrams per deciliter or greater. And these levels are high enough that they could start to contribute to things like heart attack, stroke, or other cardiovascular events associated with atherosclerosis. So again, primary hypercholesterolemia describes these elevated levels that develop independent of any health problems or lifestyle behaviors, and secondary are associated with health problems or lifestyle type behaviors. Okay, so let's talk a little bit of some of the pathology of the arterial system. And we're going to focus on atherosclerosis, arterial disease of the extremities, and aneurysms. Again, I'm going to kind of skip the discussion of vasculitis for now. So in the development of atherosclerosis, so there are 3 types of lesions that we may see inside of the arterial vessels. Remembering that atherosclerosis is defined as that hardening that we see of the arteries. One type of lesion are what we call fatty streaks. They are thin, flat, yellow, intimal discolorations that progressively enlarge, and these really are found and kind of occur in everyone. We find them in children, and often by about 20 years of life, they either start to recede or they might start to progress. but they're not necessarily definitely going to lead to atherosclerosis, but in some may progress to different types of lesions that will. The big one here, the one that is described much more in depth in your book, there's a nice kind of description with pictures that shows kind of this whole cascade of how this type of plaque causes atherosclerosis. But these are the fibrous atheromatous plaques. So kind of this cascade that happens here is there's some type of endothelial cell injury, like we talked about before, whether it's from hypertension or elevated cholesterol levels or toxins from smoking. Whatever the cause is of that endothelial cell injury, that's what starts this process of fibrous atheromatous plaque formation. So once that endothelial cell injury happens, we get migration of inflammatory cells to that area of injury. Things like macrophages and other inflammatory chemical mediators kind of come to the site and cause more inflammation of that endothelial cell or the endothelial tissue. Okay. Following that step, we start to get smooth muscle cell proliferation. So all of that kind of extracellular matrix proliferation that we talked about earlier that the vascular smooth muscle sends in response to tissue injury, right? So it sends things like collagens and other kind of fibrous material towards that endothelial injury. And along with that extracellular matrix proliferation, we also get lipid deposition, deposits of lipids, inside of that area as well, inside of that area of injury. And all of that stuff starts to gradually cause this development of this plaque inside of the vessel wall. And it usually has kind of a thick lipid core because lipids had come to the area for when that injury occurred. So overall, this is an accumulation of intracellular and extracellular lipids, proliferation of vascular smooth muscle cells to the site, and formation of a scar tissue or a cap. And this all leads to this atherosclerosis development. Okay, so now you have this kind of hardened, roughened plaque area inside of the artery. These lesions can become complicated lesions if they contain things like hemorrhage, if they start to ulcer or kind of break open, or if they lead to further kind of scar tissue depositing inside of that artery itself. Okay. So what predisposes people to the development of atherosclerosis? Well, hypercholesterolemia, so high levels of cholesterol, cigarette smoking, untreated hypertension. There's also a strong familial link here. So anyone with a family history of premature coronary heart disease and a first degree relative. So things like mother, father. And when we talk about premature, it's usually in men before the age of 45 and women before the age of 55 is what we would consider premature development. Men are typically more prone to atherosclerotic development than women until women hit menopause, and then those numbers even out. So there's protection against atherosclerosis, heart disease in general for women pre-menopause, but then their risk starts to more closely resemble men, usually after around the age of 55 or so. Other risk factors, HDL cholesterol levels below 40, elevated CRP levels, and elevated homocysteine levels. And you can kind of read about what those components are in your text. So some major complications of atherosclerosis. So the big ones are things like ischemic heart disease, cerebral vascular disease, which leads to stroke, and peripheral vascular disease, which we'll talk about today. So what's happening with atherosclerosis and why it leads to complications that we just mentioned, those atherosclerotic plaques lead to narrowing of the vessel. And if that vessel gets so narrow that there isn't sufficient blood supply to the tissue, you can start to get ischemia of the tissue. Ischemia is not enough oxygen and nutrients to the tissue itself. If the plaque inside the vessel ruptures or hemorrhages, it can cause complete vessel obstruction, which can further lead to things like ischemia or infarction, which means death of the tissue that's being supplied by that blood supply. We can also get thrombus formation, which can occlude the vessel, or we can get emboli formation, and emboli is a thrombus that's traveling and can occlude itself in a smaller vessel. And atherosclerosis can also lead to aneurysm formation, which we'll talk about in a little bit. So, specific kind of descriptions of the problems related to atherosclerosis in different arteries. In really large vessels, large arterial vessels, the important complications are related to thrombus formation and also weakening of the vessel wall itself. And that weakening can lead to things like aortic aneurysms. It can lead to dissection, and another thing we'll kind of talk about in a bit. In medium-sized arteries, we see more complications from things like ischemia and infarction due to occlusion of those vessels. And the most common, or the most, vulnerable organs that are affected by atherosclerosis are things like the heart, the brain, the kidneys, lower extremities, and the small intestines. Those are the most frequently involved organs with arterial involvement of atherosclerosis. So clinical manifestations of atherosclerosis, so this causes narrowing of the vessel and production of ischemia at the target organ that blood vessel is feeding. If a vessel becomes suddenly obstructed, that can happen due to plaque hemorrhaging or rupture. We can see thrombosis and formation of emboli that travel and lodge themselves, and that often happens when there's damage to the vessel endothelium. And again, aneurysm formation if the vessel walls start to weaken. All right, so let's focus on one of those kind of organ damage pieces that we see with atherosclerosis, which is arterial diseases of the extremities. So typically arterial diseases that cause lack of blood flow to the legs. So there's several listed here, but I'm going to focus on that atherosclerotic occlusive disease. So this can happen suddenly. It's a sudden event that interrupts arterial flow to the affected tissue or organ. So if this occlusion is acute, meaning it happens suddenly, we get the 7 P's of acute arterial embolism. So they are pistol shot, which is acute onset, pallor or paleness, polar or cold, pulselessness, pain, paresthesia, which is numbness, and then paralysis, which is loss of movement. So these are the things that are typical of the extremity that has suddenly lost or acutely lost blood flow. Okay. So that's sort of the acute manifestation, so that sudden disruption. But this can also be something that sort of develops slowly over time, where we get plaque buildup and eventually, potential occlusion of the vessel. So we call this atherosclerotic occlusive disease, or more commonly, we call it peripheral arterial disease. The risk factors for this are really the same as the risk factors for atherosclerosis, because that is what's causing this atherosclerotic occlusive disease. Clinical manifestations that we see. So some of the things you'll see in your patients, one major clinical manifestation is something called claudication. And what that means is when your patient is up and walking around, they'll start to get kind of this severe sort of cramping, burning pain, usually in the calf muscle. And what that is that when someone's up and walking around, that calf muscle is working harder, it needs more oxygen supply. But with that occlusion of that vessel, because of atherosclerosis, we're not getting appropriate blood supply. And so the reaction of the body is to send pain signals, right? And then usually these patients who experience claudication, if they rest and stop working that muscle, reduce the oxygen demand, that pain goes away. Other clinical manifestations you might see like thickened toenails or a loss of hair on the extremity with the occlusion. You might see a reduction in pulses, right? If you have an occlusion on the right leg, you might see reduced pulses to the feet. Those feet might be cool and pale. So those are some of the common clinical manifestations. Diagnosis, we would start diagnosis by looking for all of those clinical manifestations. We can do Doppler ultrasounds and check various pressures in the lower extremity to assess for a reduction in blood flow. That's often kind of the way we would diagnose peripheral arterial disease. And treatment, some treatment involves trying to take away whatever atherosclerotic risk factors there may be, right? If a patient is smoking, we would encourage smoking cessation. We would encourage use of lipid lowering drugs. There are surgical treatments that can help to open or stent open those arteries. If the occlusion is severe enough, we can do bypass surgeries on those arteries. There are some supportive treatments that we can use with patients. One thing that we often encourage patients to do is actually increase ambulation kind of slowly for patients, especially those with claudication. And what we're trying to encourage is kind of like a collateralization of circulation around that occlusion to try to reduce the ischemia to the tissues. Okay, so next thing we're going to talk about aneurysms. So aneurysms are these localized dilations of a blood vessel. So an area of the blood vessel itself that's kind of dilated or enlarged or kind of like pouched out, right? I always think of this like, you take a balloon and you blow it up one time, right? And then you let it kind of go. It kind of stays this kind of dilated and pouched out looking thing. That's how I kind of picture an aneurysm. These can occur in veins or in arteries, so we can get aneurysms in either. We'll talk about some arterial aneurysms. There's a few different types. One is called a Berry aneurysm. Usually we find these, like in the circle of Willis, which is part of the circulation within the brain. And you can see that that's that top picture in A, where there's sort of a lot of bifurcations in the vessels. So we usually see these Berry aneurysms around places where there are like kind of circular bifurcations. Again, that's why we see them in the circle of Willis. But they're just these small, like kind of spherical vessel dilations. So you can see that kind of up here in the corner of that circle of Willis. The much more common type are these fusiform or saccular aneurysms. So these are true aneurysms, meaning they're completely enclosed by all the layers of the artery itself. They're usually found, the most common place where we see aneurysms like this are in either the thoracic or the abdominal aorta. So you have that big aortic arch that comes off the left ventricle and it travels down through the thoracic aorta and down into the abdominal aorta. And that's where we see the majority of these aneurysm formations. And they really are characterized by like this kind of gradual and progressive enlargement of the aorta. So it just starts to kind of dilate, grow, and kind of stretch that vessel itself. So a little bit more about those about aortic aneurysms. So those either in the thoracic or the abdominal area. The two most common causes of aortic aneurysms are atherosclerosis, which causes weakening of the vessel walls and causes them to dilate, or something that causes maybe degeneration of the vessel media itself, that kind of middle sort of muscular layer of the artery. So things like hypertension can cause like weakening of the walls. One of the biggest groups of folks who develop these are men over the age of 50 who smoke. Aneurysms tend to be, for the most part, asymptomatic. Most folks may not ever know they have an aneurysm oftentimes until they might rupture. For some patients, you may be able to see or palpate kind of a pulsating mass within the abdomen. Usually that happens if the aneurysm itself is maybe greater than 4 centimeters in size. You may also be able to hear a bruit or kind of that sloshing sound through that blood vessel if you put your the bell of your stethoscope on the patient's aorta. A lot of the time we find aneurysms as a secondary or kind of incidental finding in imaging for other things. Some patients do develop symptoms if the aneurysm is big enough to kind of impinge on other structures like the spine, or if it's thoracic, it might impinge on like the um, um, larynx and things and cause like hoarseness. But for the most part, people don't really know they're even developing them. Another common thing that might happen is because of that dilation in the artery, we get a certain degree of stasis at that site of blood. So they may start to develop thrombi or thrombus formation that can either occlude the vessel or break off and become embolized. So sometimes that signals that there's an aneurysm forming. But the biggest risk with these, again, is rupture, where they just kind of burst and the patient bleeds a lot very quickly. Rupture is directly correlated with size. So the larger the aneurysm, the more likely they are to rupture. So if we find these and they're relatively small, a lot of the time we just kind of watch and wait, keep patients' blood pressure down, try to prevent any, don't smoke, don't do any of the things that would make it worse. And then we just kind of image and watch, right, over the years. Once they get over about 5 centimeters in size, then every year there's an increase of 5 to 10% increased risk that they might rupture. For some patients, once they get big enough, maybe over 5 centimeters, and that rupture risk gets high enough, we may surgically resect or repair them to prevent rupture, if possible. But that's depending on comorbidities of the patient. It's a major surgery. Can they tolerate it? So sometimes we just kind of watch and supportive treatment. The other type of damage we can see to arterial walls themselves is dissection. So this picture shows aortic dissection. You can kind of see that longitudinal sort of tearing or opening of the intimal wall itself of the artery. So this is an acute life-threatening condition. We're getting major hemorrhage into the vessel wall with this kind of longitudinal tearing. So we're getting hemorrhaging into the vessel wall. It's weakening it and causing it to just kind of slowly rip or tear open. And we get this kind of big blood-filled channel. Again, this is an acute life-threatening condition. The most common folks we see these in are men with long-standing hypertension. There are also some people who maybe have underlying like connective tissue diseases that may be more predisposed to these. One group specifically associated with aortic dissection are those who have something called Marfan syndrome. We talked about that back in the congenital piece. They can also be a surgical complication. We see these in like cardiac cath procedures where we're manipulating wires and other catheters around in the aorta that can cause dissection. We see it during surgical repairs of maybe valves. For some patients who have like congenital aortic valve disorder, or who had what we call coarctation of the aorta at birth, which is like a narrowing, they're more predisposed to, probably just because of the changes to the pressures in the artery wall themselves. So a major symptom, one of the first most major symptoms of dissecting aneurysm, is just this abrupt, excruciating, like kind of tearing or ripping pain. If usually in the chest or maybe in the upper back, it usually presents itself very obviously in that way. And so if someone presents like that, we need to definitively diagnose the dissection. So we try to stabilize these patients first. One of the things you see right away during a dissection, if someone's starting to dissect, their pressures will initially kind of go up, which truly makes the situation worse, right? So we have to stabilize these patients by trying to aggressively bring their blood pressure down to try to stabilize and reduce like that kind of tearing that we're seeing in the aorta, definitively diagnose this, and then they go for surgical repair. If this is allowed to progress, these patients, after that initial hypertensive phase, they start to lose pressure kind of everywhere, right? Like if you're dissecting at the aorta, the aortic arch, you're losing blood flow everywhere else. So they'll start by like losing blood flow. They go pulseless in their extremities, and eventually, can lead to high levels of mortality if it's not dealt with. And it progresses very rapidly. Even for patients who have surgical repair, They often have a really kind of long road to recovery, usually related to the amount of like kind of ischemic damage that happens everywhere else, right? Like, if there's a big loss of blood flow, like to the gut, they may have big portions of their gastrointestinal system that are ischemic and need to be removed. They might have had a whole bunch of ischemia to the lower legs or arms. So they just have a lot of complications, even if we can correct these. All right, moving on. So we're going to move away from arterial circulation to venous circulation. So remembering that in the veins, our valves have these our veins have one-way valves to try to prevent backflow of blood. We want the blood moving up towards the heart. Veins don't contract. The skeletal muscles movement around veins acts as a muscle pump to help return blood to the circulation. And these are very thin-walled vessels. We have superficial veins and deep veins. So the superficial veins are closer to the body's surface, and so they're kind of collecting blood from like the little capillaries and everything from the skin. And then there's communicating veins that connect the superficial veins to the deep veins. And so then those little communicating veins move the blood from the superficial veins to the deep veins, and then the deep veins move things back up towards the heart using that kind of skeletal muscle pump. So if we have disorders of venous circulation, these things usually produce some kind of congestion of the affected tissues. So if we can't return things like blood and then lymph to the heart, it starts to congest or pool itself in the lower extremities. So this looks like things like edema, right? Because there's stasis in that venous circulation, that stasis of blood predisposes these patients to things like clot formation because of that stagnant blood flow. And it can also, in and of itself, activate the clotting system to further increase the risk of clot formation. Some patients develop varicose veins. You guys can kind of read through that. I'm not going to focus on that too much, but you can take a look at that in your reading. We'll talk a little bit about thrombophlebitis. So with thrombophlebitis or venous thrombosis formation, there are kind of three big things, what we call Virchow's triad, that are associated with the development of clots in the venous system. So one, again, is that stasis of blood. Another is increased blood coagulability, and then vessel wall injury. So if we have these three things, we have a patient that is very predisposed to thromboembolus formation. So we've talked about a lot of the things that are associated with venous stasis already. So things like bed rest or immobility. So patients like post-ortho surgeries like hips and knees are at really high risk. Spinal cord injury patients, heart attack patients, CHF patients, patients in shock. They are hypercoagulable and they have a lot of stasis. And they have a lot of inflammation. We talked about increased risk of venous stasis in patients with cancer. Anybody with venous obstruction will have venous stasis as they're not returning blood back to the heart. Okay. Some of the things that remembering that cause hypercoagulability, right? Remember things like high estrogen levels. So use of oral contraceptives is another piece here. So another issue that we can see develop within the veins is something called venous insufficiency. So deep vein thrombosis, patients who have had deep vein thrombosis are at higher risk of venous insufficiency because that thrombus formation causes deformity, often of the valves within the veins that would prevent backflow. So that's a big cause of venous insufficiency. And we have general valvular incompetence. So we lose that kind of unidirectional or back toward the heart flow of blood. And so we get, again, a lot of backflow, a lot of kind of like just pooling and of blood and like stretch or expansion of those veins themselves. Okay. And the two big things that are associated with venous insufficiency, the changes that we see usually in the lower extremities when someone has these issues, are stasis dermatitis and then the formation of venous ulcers. So stasis dermatitis, this is caused when we have this venous insufficiency. Over time, we get kind of a reduction in the nutrient levels that would typically feed like that subcutaneous tissue in the lower legs. And so stasis dermatitis looks like this kind of really thin, shiny, sort of bluish brown, irregularly pigmented skin. And it's very thin and doesn't have the same like underlying subcutaneous support tissues that we normally have. And so stasis dermatitis makes these patients very prone to tissue injury, especially in the lower extremities. And that in turn leads to the development of what we call venous ulcers. Venous ulcers usually appear over like kind of bony prominences, kind of over the bony prominences of the ankle are really common. And they are just really difficult. You guys will talk about these in your chronic health course, but the thing to know about them is that they are extraordinarily difficult to heal. They take a really long time. They can easily become infected. They're just really kind of, I guess I'll use the word persistent, and again, difficult to heal ulcers, directly caused by that loss of like valvular competence and loss of that unidirectional flow. All right, so we also need to talk about these disorders of blood pressure regulation. And so we talked about, you guys already did some activities that looked at the different mechanisms in the body that regulate blood pressure, but we need those regulatory mechanisms because we want to make sure that blood pressure is high enough that we have good perfusion to the tissues, but that it's not so high that it's starting to cause damage to the blood vessels themselves, because we've just talked about all the things that can cause or that can be damaged by all this persistent hypertension. So again, if you don't have sufficient blood pressure, if your blood pressure is too low, your tissues don't receive sufficient blood flow, they don't get nutrients, they don't get oxygen, and they also can't remove any cellular waste. If your blood pressure is too high, it can start to damage those endothelial tissues, and that can lead to atherosclerotic plaquing, vascular disease, vascular rupture and occlusion. So that's the risk there. So we really need to keep that blood pressure in a kind of nice regulated space. So hypertension is a sustained condition of elevation of the blood pressure within the arteries. We'll look at what the numbers are, like the specifics from the American Heart Association in a moment. But hypertension, as far as etiology of hypertension, things like sedentary lifestyle, metabolic diseases like diabetes, poor diet, like elevated levels of saturated fat intake. Hypertension also has familial components, so it tends to run in families. There's also a component of sex. Men tend to be more prone to hypertension than women. There are ethnic components. We see some of the highest rates of hypertension in African American patients, and not only do they have higher rates, but we tend to see hypertension that's more difficult to control and at higher levels than in other patients. Things like elevated levels of long-term stress can lead to hypertension. We'll talk about primary and secondary hypertension in a moment. As far as clinical manifestations, one of the things about hypertension is it really doesn't have a lot of clinical manifestations as it progresses, right? Like it's very much a silent disease. People don't know they're experiencing hypertension until it starts to lead to things like end organ damage, right? It leads to things like atherosclerosis that cause heart attacks, or damage to the heart, or it leads to strokes, or it leads to things like dementia. It leads to things like kidney damage or kidney disease. It leads to things like damage to the eye. So again, usually clinical manifestations are related to long-term hypertension that starts to damage organs, right? As we talked about, like peripheral vascular disease, those kind of things are the clinical manifestations that arise from hypertension over time. So diagnosis and treatment. Diagnosis is based on serial measurements of blood pressure that lie outside of those normal hypertension ranges that we'll talk about in a moment. And treatment is, we can start with maybe lifestyle changes, maybe adding in exercise and improving diet, maybe stress reduction techniques. If that doesn't work, then typically medical management, where we start with maybe diuretics or ACE inhibitors, and then we just keep kind of adding in more and more medications until we can get blood pressure under control. Also, in those patients, they of course would need to be more closely monitored to watch them for kind of all of those end organ clinical manifestations that we just mentioned. So again, here's your risk factors. So age, risk of hypertension goes up as we age, more likely in men. African American populations have higher rates. This does run in families. There are dietary components. Smoking, of course, predisposes. Also, those who have high rates of alcohol consumption tend to be hypertensive, and patients with obesity also develop hypertension. So that's really primary hypertension. There's also secondary hypertension, and this is hypertension that is caused by, has a known distinct cause. And with secondary hypertension, if we can find and eliminate that cause, we may also be able to eliminate the hypertension. The most common cause of secondary hypertension results from some kind of kidney disease. That's the usual reason that patients have secondary hypertension. If we solve the kidney disease, the hypertension hopefully goes away. So maybe it can be corrected by either surgery or specific medical treatments. Again, the largest single cause of this is renal disease or renal hypertension. Other causes of secondary hypertension, primary hyperaldosteronism, so where we have all this excess aldosterone secretions that are causing sodium and water retention. Cushing disease, same kind of mechanism there. Pheochromocytomas, those are tumors of what we call chromaffin tissue, and those tumors contain sympathetic nerve cells that are constantly releasing catecholamines, and catecholamine release is what's causing the hypertension. The other cause is oral contraceptive drugs. Some patients develop secondary hypertension from those, and the treatment is to withdraw the drug. So again, the biggest clinical manifestation and the thing that we're most concerned about with hypertension is the organ damage that it causes. In the heart, because of the increased workload, we start to see left ventricular and sometimes right ventricular hypertrophy of the cardiac muscle itself. And over time, that causes weakening and heart failure itself. We'll talk about heart failure a little bit more, and I think next week. We see elevated risk of things like dementia and cognitive impairment in patients with long-term hypertension. They're, of course, at a higher risk of things like cerebrovascular accidents or stroke, higher risk of peripheral vascular disease due to atherosclerosis, kidney disease due to nephrosclerosis. They develop things like retinal complications. And hypertensive emergency is also something that happens in some patients. Hypertensive emergency is defined as blood pressures over 180 over 120. So here are the numbers. According to the American Heart Association, to have a normal blood pressure, you want a pressure less than 120 over 80. We consider 120 to 129 over 80 as elevated. High blood pressure or hypertension stage 1 at 130 to 139 systolic and 80 to 89 diastolic. Hypertension stage 2, 140 over 90 or higher. And there's your hypertensive crisis, 180 over 120 or above. So that was high blood pressure. Let's talk about what happens when your blood pressure is too low, or more accurately, that you can't maintain a normal blood pressure when changing positions. And so we call that orthostatic hypertension or postural hypotension. So what we see is this abnormal drop in blood pressure when someone moves into a standing position. So there are some specific numbers you have to hit. So it's a sustained reduction in systolic pressure of at least 20 millimeters of mercury or more, or diastolic blood pressure of 10 millimeters of mercury within 3 minutes of standing, or head up tilt on a tilt table of at least 60 degrees. So again, very specific measurements. Everybody's pressure is going to drop when they stand up, but it's that the amount and the sustained nature of it that is more closely related to orthostatics. Okay. Let me talk about etiology here. So the most common causes of orthostatic hypotension are things like fluid deficit. So patients who are, experiencing significant fluid deficit will become orthostatic when they stand up. A lot of medications, a lot of blood pressure medications, diuretics, anything used to kind of treat hypertension itself predisposes patients to orthostatic hypotension. There are a lot of psych meds. A lot of the antidepressants do it. I think some of the antipsychotics will do this. But anytime you see a med with a side effect of orthostatic hypotension, you should be implementing kind of safety interventions that we'll talk about in a moment for those patients. Patients are more likely to develop this as they age. Some patients with maybe defective function of the ANS. So we see this maybe in patients with diabetes who are starting to have nerve damage. There's postural orthostatic tachycardia syndrome, which is a autonomic kind of disorder that can lead to this. And then finally, the effects of immobility. We talked about this a little bit in 2015, but a patient who is on long-term bed rest is very prone to orthostatic hypotension, especially kind of that first kind of up out of bed piece of that. So how do we treat this? Well, if we have a known cause, like a medication, we implement safety measures where we would ask patients to kind of change positions slowly, sit up and dangle your feet and then stand up. We would ensure proper hydration for these patients. There are some medications that can bring blood pressure up and prevent drops in blood pressure. We may use those, especially for patients who are very prone to syncopal episodes and may lead to things like falls. But in general, we just use kind of supportive therapies where we increase fluid, maybe increase salt intake, and ask patients to kind of really use care when standing. We can also review medications to make sure we don't have interactions that can be removed. Again, the largest issue here, though, is safety. So things like implementing fall precautions, anything we can do to keep the patients upright. And that is the end. Please let me know if you guys have any questions, and we will go over this again later.